on the uveitis. So to start with, let me welcome Professor Carlos Pavesio, who does not need any introduction in the field of uveitis. Professor Carlos Pavesio, over to you.
Thank you very much, Rupesh, and thank you for the invitation to speak. It's a pleasure to join the group and share the experience in this topic of scleritis. Just see if I can share my slides. Okay, so scleritis, I'll just give you a very broad overview of aspects related to the clinical manifestations, some of the importance in diagnosing potential associations and management issues. I think the important thing to remember that scleritis can be caused by a variable group of diseases. So it's not just one specific problem, but it can be quite variable. And the inflammatory response is centered in the sclera, but the tissues which are adjacent can be affected too. So it's not uncommon for you to see involvement of the cornea or involvement of the trabeculum, so patients developing problems with pressure, or intraocular involvement the posterior segment. So this is something that can happen in very aggressive forms. And also you have to remember that sometimes the inflammation of the sclera can be caused by a primary intraocular inflammation, which is then reaching the sclera, and you'll hear about toxoplasmosis later on. It's one of the potential causes of scleritis, as well as herpes viruses, as a retinitis causing scleritis. Even though it's uncommon, it is a potentially blinding condition, and there is a very potential association with systemic disorders which can kill the patient in a short time if not recognized. So this is a classification which was proposed many years ago, originally by Watson and Hayre, and that has been recently modified. I think Professor Rao has been involved in that process, but it shows very clearly that you separate, especially focusing on the scleritis, into anterior and posterior disease, and all of them potentially in diffuse, nodular, and necrotizing. When we look at the necrotizing anterior scleritis, we have different manifestations. In the past, we would say necrotizing scleritis with inflammation and without inflammation, which would be Scleromalacia perforans, and the other forms would be the inflammatory forms. So you have vaso-occlusive, the granulomatous form, and the SINS, which is surgically induced scleritis. Just to give you here this very schematic illustration of what it looks like. Remember, the sclera itself is not vascularized. It is supplied by choroid internally and episcleroplexus externally, and the episcleroplexus can be superficial and deep. So when you have an episcleritis, it is the superficial episcleroplexus which is involved, so the sclera itself is not involved. And you can see in your examination that the redness is on the superficial vessels. You don't get the deep hue that you see in true scleritis, which is involving the profound deep episcleral plexus, and that will generate a redness, which you can see is deeper. Ways of separating this, you always heard about the issue of the phenylephrine 10% test, which is something we haven't been using these days very much because of the risk of cardiac events in some of our older patients. But if you examine the patient with a green light, you can tell where the redness is coming from, or put the patient on natural light, so it's easier to also tell the difference. The anterior, diffuse, and nodular are put together because even though they clinically look different, many of the other aspects are similar. There are less aggressive forms. They occur in individuals about the same age group, 40 to 60. They're less associated with ocular complications and still have an association with systemic disease of about 40% of the cases. So just to show here what happens with the inflammation of the deep episcleroplexus. So the sclera itself gets swollen, and as I said before, that swelling can eventually, inflammation progress into the eye, involving the choroid and potentially leading to complications, which I'll show you in a bit later on. This is a case of diffuse scleritis, anterior scleritis. You can see some corneal involvement here in this slide at the top. And the reason for these images below is to show that if you do an angiogram, and you can use ICG is better than fluorescein because it doesn't leak profusely, you can identify if there are areas of occlusion. And if you see occlusion, it's an indication that this is progressing towards a necrotizing form. These are examples here of nodular. Usually the nodules are a few millimeters behind the limbus. They could be one or more, and usually they recur in the same area. That's a very typical thing to see. And if you have several recurrences, very commonly the area affected, you can see a change in the color of the sclera, because the collagen changes configuration and allows you to see through to uveal tissue. The necrotizing form is much more serious, not only because it's destructive to the globe itself and can result in visual loss more than the other forms, but also has a high association with systemic disease, with 29% of the patients potentially dying within 5 years of the diagnosis. So you can see there's a high risk of ocular complications, visual loss, and potentially more serious life-threatening problems. The patients here tend to be older. It's also most of the times a bilateral condition, but it can be unilateral. The pain is out of proportion to what you see in the examination. So the patients really present to you with unbearable pain. And there is a very strong association of this form with a systemic disease. So you see about 90% of the cases. So this is a peripheral ulcerative keratitis, which I just put in here to remind you that if you see this, this is already an indication of a systemic vasculitis. So this is a situation when you have to look for an underlying vasculitic disorder, because this is causing ischemia in that area, causing this gutter in the periphery. These are examples here of necrotizing disease, and you can see it's very easy when you see these whitish areas of melting of the sclera, which then also involves the conjunctiva, so these areas become not covered by conj, and of course, as they resolve, they leave extensive areas of change in transparency, but if you lose tissue, you can also progress to staphylomas. So what you see here is a demonstration of the use of the technique of angiogram to identify vessels which are closed and are the reason why the patients are developing this phenomenon. This is another example here, which is another case of ICG angiography in one of my patients in clinic, just to show the extensive areas of non-perfusion that they experience during the acute event. So this is to show you the progression, how quickly it can be. This is in March, this is a long time ago, and it shows very quickly how this went from just involving the limbal area to destroying pretty much all the sclera superiorly to the cornea. Once they resolve, they'll leave, as I mentioned before, either areas of transparency or real thinning, and then bulging, which is the staphyloma, even with normal intraocular pressure. So these are great examples of how this can develop and result in structural damage to the sclera, and consequently significant changes to the corneal curvature. So these patients very often have very deep astigmatism. Just an example here of this kind of just a little buttonhole type of picture with uveal tissue prolapsing through that scleral hole and just covered by conjunctiva. Surgically induced is the form that is associated with an existing procedure in the past, and that can be from weeks to years after the procedure. We see that frequently in patients who have surgery like pterygium surgery, enhanced the effect of mitomycin, patients who had screen surgery or the old extracapsular procedure when the incision was scleral, and the inflammation really can vary, could be since the beginning, but it can really take several years to develop. And there is a strong association with a systemic disease in 50 to 90% of the cases. So the reason for that is likely that the original procedure induced some vascular changes locally, and there's abnormal vessels in the future when the patient is older and develops a autoimmune disease and will have circulating antibodies. These circulating antibodies will preferentially deposit in these abnormal vessels and then trigger the initial response which will generate the scleritis. That's the reason for the gap, which can be so many years after the fact. So these are some examples of cases which were post-vitrectomy. So it's not common to see that, but we have a series of patients who presented with necrotizing scleritis following vitrectomy. It's really important in all cases of necrotizing scleritis to be absolutely sure that there is not an infection going on. So you have to take a sample, because it could be a bacterial infection, which then, of course, will result in melting as well. So clinically, it may be confused, but if you take a sample, you guarantee that you're excluding that, since the management is going to be very different. So these are some examples here. You can see very well plaques, in this case being multifocal. It makes you think more of an immunological process than an infective process. And these patients here resolved only when they were treated with infliximab. This is a long time ago. This when infliximab was just beginning to come out, and we were lucky to be able to use, but they were not responding very well to conventional therapy. This is another example here. Scleromalacia perforans is what used to be called the necrotizing scleritis without inflammation. So this is an older patient, very frequently females. It's one of the real predominance of females. These are usually people who have suffered very badly with rheumatoid arthritis, and the rheumatoid arthritis is really serious. You see, look at their hands, and there's many times stuck on a wheelchair because of the disease, and they present with this. How they present? Well, this is not a picture they walk in with pain. Many times they come in to be seen because someone told them their eyes look different, or the vision may be changing because of astigmatism, and it's not because of pain. And usually not a very red eye, might be very minimal changes to the surface. But you see it in the eyes, you can tell. I'll show you an example how different it looks because of the damage to the sclera. But what I find is you will find some yellow plaques. Those plaques are areas of sequestration. So the reason for the difference between the one with inflammation or inflammation is where the occlusion is occurring. In this form here, we believe it's an arteriolar occlusion. So there's an infarct leaving the sequestrum, which then gets absorbed and leaves you with the area of staphyloma. In the other forms I showed you before, we believe it's a venular occlusion. So it's very much like having the similar situation of a vein occlusion in the retina, hemorrhages and more severe involvement of the tissues around. So the venular event in the sclera would be a similar situation of a much more severe presentation. So here an example, you can see this patient really is not complaining of pain, did never complain of pain. You can see areas of sequestration here, so areas which are still progressing, but look at the size of this staphyloma and the large areas involved. You can imagine this must have been a very painful thing, and actually this wasn't a painful thing. This patient, I always make a bit of a joke here because this patient was referred to me for cataract surgery by someone that until then I considered a friend. But you can see very well that the difficulty in operating this patient is exactly the approach. Now we have to choose very carefully how you're going to tackle this cataract, and clearly, luckily now with phaco is much more possible. Imagine doing this with a capsular as we used to do in the past. These are other very extreme examples of scleromalacia perforans, so painless presentation with extensive destruction of the sclera. Shifting from the anterior to the posterior scleritis, which is important, the message here for you is that a posterior scleritis is a serious problem. It's underdiagnosed. It is occurring in a part of the back of the eye where you can involve the optic nerve, the macula, so it is potentially a blinding condition. And it lacks many times science that will make the diagnosis possible. So it relies a lot of the times in investigations, imaging to help us make the diagnosis. So there is an association. Age of the patient is variable. We have had patients who are very young, as young as 5, and we have had older patients as well. In young people, the likelihood of having any association with a systemic problem extremely low. But in older age group, you can find about 30% of the cases having an association with a systemic disease. So these are some of the issues that will make your diagnosis easier in terms of thinking about it, because these are common manifestations of complications associated with a posterior scleritis. So this is schematically showing the serious detachment that makes posterior scleritis a differential diagnosis with VKH. Again, here you can see a mass in the choroid, so it's reflecting the presence of this lesion, scleral lesion right behind that area. The folds here that you can see, the retinal folds, and you can see here in the angiogram the involvement of the choroid and the retinal pigment epithelium. This is something you can see again, a mass, a subretinal mass, and many times the subretinal mass may not disappear completely even after the patient is treated and the inflammation is resolved. You may remain with this subretinal abnormality. These are typical choroidal folds going horizontally across the posterior pole and typically representing a reduction of the arc of curvature of the sclera induced by the inflammation and the swelling of the sclera. Again, another case with the retinal folds and involvement of the optic nerve. You can see the swelling of the nerve, the retinal folds and fluid, of course, associated with this posterior scleritis. The B scan represents your best friend in terms of diagnosing this. So you can see the thickening. When you measure the thickness of the back, you don't measure the thickness of the sclera independent of the choroid. You're usually measuring the thickness of the posterior coats of the eye. Normal is about 2 millimeters or around that. And you can see a thickening. And if you see thickening of the posterior coat with fluid generating this dark line, especially if you have the T sign, which is going to be the typical manifestation of a posterior scleritis. Some of the patients will show more of a nodular appearance, as you can see here. Some others are going to be more diffuse. I don't think I have actually, even though the classification talks about necrotizing posterior scleritis, I don't think I have seen a case. I think the vascularization of the back is more protective from a total necrotizing event. This is an example here, which I have showed you before, which can be easily confused with VKH, the presence of these multiple areas of leakage from the RPE and the accumulation of subretinal fluid associated with a posterior scleritis. So what I mentioned before, it's not to be forgotten that infectious scleritis has to be considered in patients with a necrotizing disease. So they'll take a sample to make sure. It's more commonly seen in patients who had a trauma or a surgical intervention, so buckles for a long time. And of course, fungi would be in case of trauma, vegetable matter mostly. Viruses, the herpes viruses, especially can cause direct involvement or coming secondarily from a retinitis. And parasites, I mentioned toxoplasmosis before. And remember, acanthamoeba was a problem many, many years ago when we had this epidemic of contact lens related acanthamoeba infections of the cornea, but also sclero involvement, with seriously painful eyes with scleritis. So the examples here, this is a patient actually with leprosy. You can see the nodules here, and this they're developing a diffuse nodular scleritis, be more typical of TB, for instance, or leprosy, but some patients can present with more diffuse disease. These are examples here of patients who underwent retinal surgery and developed more like a Pseudomonas case. This is a Staphylococcus case. So these are cases that you have to be careful. And this you can see here very easily. Patients who present primarily with a corneal infection can eventually develop invasion, extension into the sclera. How do you treat this patient? So, of course, if it's infectious, you're going to deal more with specific treatment for that infections. You may have to debride the area of infection to clear penetration of the drug. Access by the drugs to the sclera is not easy, so you have to facilitate, and topical therapy is important, and systemic therapy will be added as well. If we leave aside the infectious diseases, just mentioning here, non-steroidals are very helpful, but not in necrotizing disease. Topical therapy is not helpful in changing the course of disease, but may help with the symptoms. And of course, the use of steroids orally or intravenously in very severe cases will be the best way of bringing it under control. In some patients, of course, the disease responds well initially to the steroid, but then, of course, will not respond well when the steroids are reduced, and they will have to introduce a second-line agent to maintain control, and then we escalate if necessary to biologics and surgery as a last resort, and I'll show you a little bit why. So the second-line agents, all of these agents have been used. I think methotrexate especially has a good effect, but you can try cyclosporine, not a very good option, just like an alternative in case the others are failing. But these days, with the use of biologics, the need for cyclosporine becomes less. Cyclophosphamide, extremely effective in the patients who had ANCA-positive scleritis, so granulomatosis with polyangiitis. These patients, the GPAs tend to do well with cyclophosphamide. And biologics, of course, can be also used. Infliximab, I won't spend a lot of time here, but just mentioning for you the efficacy of this alternative also being explored, and we have seen response in many patients. This is a study from Jim Rosenbaum's group in Portland, Oregon, showing the use of rituximab in patients who had failed to respond to other alternatives, refractory cases of non-infectious scleritis, and showing that it did achieve response in some patients regarding requiring further infusions after some time. So this is the rituximab work showing the benefit of this strategy. Posterior scleritis, just a message here, all patients have to be treated aggressively because of the risk of visual loss. So we never know, we cannot tell in advance who may lose vision or not. Surgical intervention is left really for situations when you have the risk, or you have a perforation, or you want to remove a process which, an infectious process is leading to a destructive situation, but do not plan this for just a staphyloma. A staphyloma should be left alone. Staphylomas will very rarely perforate. These are older patients who are not playing rugby, do not doing anything very aggressive, and they're not going to have blows to their eyes very often. So if you see a quiet eye with a staphyloma, do not propose to intervene just to patch the staphyloma if the eye is not a threat of immediate visual loss. I think it's left for situations of more aggressive cases when you can see the extent of surgery that may be required to replace the damaged tissue. So I think mentioning finally here one thing I didn't put before, but the local therapy has been advocated and used by some colleagues. We're always worried about local therapy injections because of the risk of necrosis, so avoid necrotizing disease. But this is being done by Narsingh Rao and our friends from Australia as well, showing that a subconjunctival triamcinolone can be very effective in controlling patients, especially those patients who have problems related to using of systemic therapy. So these are some of the cases in which it's been used, and it shows here they can be effective, it can be repeated. It is really not associated with serious complications, but of course we have to be careful with infection and necrotizing disease. In conclusion, necrotizing scleritis is the one you have to worry about with visual loss and associated systemic disease. Posterior scleritis, don't underestimate the risk of visual loss and treat it aggressively. And these are the two reasons for visual loss, mainly necrotizing and posterior. Anterior uveitis, just to mention here, is not diseases that cause anterior uveitis or uveitis and scleritis are not the same. But if you have a severe scleritis or even an episcleritis, you may develop some anterior uveitis associated with that. Topical therapy may have symptoms, but will not resolve the disease process. And subconjunctival steroids, as I showed you now, is an option, but avoiding necrotizing disease. Remember that systemic therapy in patients with necrotizing disease is the way to preserve vision and potentially treat the seriousness of this underlying disease. Non-steroidals are limited to non-necrotizing disease and should not be used for more serious cases. Thank you very much.